All right, let's talk about reperfusion treatment in acute ischemic stroke, okay? And we're gonna talk about the thrombolytics. Obviously, mechanical thrombectomy is gonna be in there as well as a reperfusion thing. It's helpful to get some sort of historical perspective on this because we've been using thrombolytic agents, for 40 years now, primarily in cardiac. And so, we've used streptokinase, we've used urokinase, we've used tissue plasminogen activator, TPA, otherwise known as TPA. We use retoplase, we use tenecteplase. And thankfully, tenecteplase has come back around, hallelujah, so that we can just have a give and go sort of situation. But all of our things that we really know about stroke really came out of the thrombolysis and myocardial infarction trials, the TIMI trials. And this will look familiar to you because as we get into mechanical thrombectomy and as they look at recanalization rates, we have TICI, which is the thrombolysis and cerebral infarction scores. And so, but all of the early trials came out of cardiology. And of course the heart's a different structure than the brain, obviously, with different vessels, different size vessels and so forth. But we took a lot of our progression from cardiology. Now I do want to talk about a little bit about these trials because we're going to talk about some. And some of them you're going to go, why do I need to know this? It's important that we know that because when we come out with new research, you need to know how to interpret it as well. People interpret, I don't know if you know that or not, people interpret research really badly. Especially if they don't understand
an
it.
example of that, or I'm kidding.
I know what you're going for.
So anyway, so I just want you to know, now the randomized double-blind placebo-controlled clinical trial looks like this. A clinical trial is obviously a research study, and you're comparing an intervention with with some other thing. It could be placebo, it could be you're comparing interventions, like we did with alteplase and tenecteplase. It could be you're comparing two things. But the initial thing that you have to do is you have to compare to nothing. You have something is either better or worse than nothing. And that's how you start out. Once you have something that is better than nothing, you don't compare to nothing again. It's unethical. You have a treatment, right? And so that's the reason why in your levels of evidence, you will have level 1A levels of evidence. Thrombolytics is in that group, but that's because they compare to nothing. Again, once you compare to nothing, you can't compare to nothing ever again. It's unethical to do that because you have a treatment that is proven effective over nothing. Does that make sense? So it's important for us to know that when we look at these and we look at, oh, these are level 2A. Well, they're level 2A and not 1A because they're comparing to something else, not placebo, okay? So that's important to know. Placebo-controlled, it's manufactured to look identical to the real thing. So in the NINDS trial, they had all the things. They looked all the same. You didn't know what you were giving. You can do double blind too. We don't know what we're giving. Guess what? The patient doesn't know what they're doing either. You need IRB for that because the patients have to consent, right? So you need an institutional review board for research. Quality improvement, you don't, but research you do because there's protection of those subjects. In the case of a procedure, procedures are a little bit more difficult, but you can do a sham method, but most people, it's really difficult to do that with a procedure. It's randomized. So literally the research coordinator, it's randomized. You don't know whether you're gonna get something or nothing. If it's an intervention, you don't know if you're gonna get the intervention or not. It's almost like a lottery situation to randomize patients. And then again, the double blind. We don't know what we're giving, the patient doesn't know what they're getting, okay? So double blind is how that works. It's really difficult to fit all that criteria, but we have some really good trials that were exactly in this design. So this is really the highest standard that you can have here. Oh, hang on a minute, okay. Let's see, where am I at? Okay. We're gonna start out with the NINDS RTPA stroke study. And obviously this sort of informed us, this is 1995. This is the research that gave the indication for alteplase for the acute ischemic stroke. So there's a couple of parts. And what they did in the first part is they just looked 24 hours. Hey, do I have a complete resolution or do I have a reduction in the NIH at 24 hours? They didn't look past that. And so that was part one. Part two is a pivotal study. And so they looked at 4 composite outcomes, and we'll look at that in just a minute. Whether the recovery extended past the 24 hours into 3 months. We had that 3-month modified ranking. Well, this is the start of doing 3-month modified rankings.
That's why we use 6, got it.
Yeah, there you go.
That's why we scored that.
That's why you scored that, that's right. Okay, this inclusion criteria will look very familiar to you, and the exclusion criteria. All of this criteria was sort of expert opinion. You know, they didn't know history of intracranial hemorrhage. What if you had an intracranial hemorrhage like, I don't know, 5 years ago? I mean, and so we don't even know what that patient population looks like. But then when you design the trials, you exclude people that might confound your results, okay? Because you want a positive trial. So if somebody had a GI bleed in previous 21 days and you give them a thrombolytic, now 21 days is arbitrary, we don't know. And you give them a thrombolytic, what if they bled and that altered your outcome? So when you look at exclusion criteria in these trials, when you look at them and you go, gosh, why did they do that? Well, they did that so they would have a positive trial, okay? So platelet count, blood glucose, blood pressure. If their blood pressure is 185 over 110, we established yesterday that that's a sort of an arbitrary blood pressure that they just got in the room and said, what's a good blood pressure that we should like not go over if we're gonna give them thrombolytics? And they're like,